Good morning, Dr. Parthaban.
Good morning. Hi.
I'll be with you in a minute, okay? Yeah, you remember how to screen share and everything, right?
Okay.
Do you want to practice?
Yeah. Is there?
Yeah, that's good.
I'm
Yeah.
okay.
Yeah, if you want to make it bigger, I think there's an option to make it. There you go. Perfect. You're all set. You're a pro.
Yeah.
We're with you in a second.
Sure.
There's Ipe. Ipe knows how to get the link. All right. Oh man, did you see Yuha yesterday? Oh man, we're getting some people. It wasn't like the last time you spoke. We're getting more people.
Huh?
Hey, John.
Hey, Ike. Good morning.
Hi.
I'm around. Hey, Parthi.
Hi. Hi.
Vlad is also there, I guess.
Yeah.
Let's see, not yet.
You may be.
He's on. He's on.
Oh, yeah.
Okay.
Can you
hold
put him
on.
on the?
Hello.
Vlad, you don't have to sing that, Vlad. We know you are there.
Yeah. Well, I saw it some spine.
There he is.
I'm interested very much in, you know it. I hope it.
Okay. So
Okay.
1 hour, we're going to have some spine. My crazy interest too in spine. So both of us will watch Parthi.
Yeah.
Yeah.
I will watch it. All right.
Speak on some basics. Yeah.
Okay,
Yeah.
Parthi, go ahead.
Well, no, hold on, Ike. Vlad, we'll work out the videos as best we can. Now, I sent you the link for his videos in case I fumble and don't get it going. You know what I mean?
Doesn't matter. If the videos will not be there, the message will be there. That's
Yeah.
important.
Okay. We'll just slowly go through them, and you point the ones you want me to play. I have the link and I have the videos as you saw yesterday.
Yeah. Well, yesterday the videos were not really the best. It's probably too large.
John, by the time you're finished, you'll be the second person who will have a lot of knowledge about supracerebellar infantatoria.
Sure you
Yeah,
will.
I know. I'll
You
be
will.
ready to operate. Huh?
You could do it tomorrow.
Man, oh man. When you start showing those pictures of those ruptured aneurysms, oh my God. My God. Call the neurosurgeons.
Yeah.
The only thing is, John, you need hands which are like 7 feet long. Vlad has got them.
Yeah.
That's it.
Yeah, delicate hands too, huh?
That's
Wow.
it.
Okay.
Well, there are hormones to grow up.
Okay, Dr. Parthaban, you ready?
Yeah. I'm fine.
Okay. 10, 9, 8, 7, 6, 5, 4, 3, 2, 1. Good morning. This is Dr. John Bennett broadcasting from Miami. We have a couple of presentations on a daily dose of neurosurgery education headed by Ed Cherian. And today we have the pleasure of having JKBC Parthaban to do the first presentation. And let's just briefly go through the panel. Can I bump you off the screen share there,
Yeah.
JC, so we can see the people we're meeting?
You can take off. Yeah. Thank you.
Yeah, there we go.
Are you able to listen to me better?
Yeah, no. You can start it. I just want to introduce the panel and we'll get to see their faces.
Thank you.
Okay, Vlad, could you please
Yes,
introduce yourself? Hi, please introduce yourself.
I can't find it.
No, just introduce yourself. You're not presenting now.
Oh yeah, Vladimir Beneš from Prague. Nice.
Take it easy. This horse wants to get out of the stable, man.
Yeah, good weather here.
Yeah, who are you? Who are you and where do you work, Vlad?
John, let me introduce him. Vlad, let me introduce you, Vlad.
Okay, go
Okay,
ahead.
do that,
Go ahead.
please.
Go ahead.
Okay. Vlad is one of the senior most and one of the most respected neurosurgeons in the world. He was the past president of European Association of Neurosurgeons, and he is one of the world renowned experts on what he's going to talk about, the supracerebellar infratentorial. It's
Great.
almost like his approach. So,
Great.
and he also has a lot of other interests. One of which is bug collecting. When we go to Africa, you can see Vlad collecting beetles all over the place. He has some beetles named after him and his wife. So he's a man of many talents.
Oh, really?
And he also has operated on some elephants. He's taken some meningiomas out of elephants. So every time I talk to Vlad, there will be something I always discover and I get impressed. And more than that,
sports.
Okay,
and
very good.
moreover, Vladimir plays very good table tennis, almost as good as I am. And then he's crazy, a bit more crazy than I am. But then I guess it's the age. So when I reach there, I hope to be more crazier than he is.
Okay, very good. Okay, why
Very
don't
good.
we go straight
Thank
to
you,
the
Ike.
why don't we
Yeah.
go straight to the presentation? Okay, Dr. Partharan,
Yeah,
welcome and thank you.
Thank you, John, and thank you, friends. Good to see you all. This is a very simple presentation, and I have made this into 2 classes. Like, this is basically done for the young neurosurgeons who are starting their career. Right? It's a very interesting talk and very interesting topic also, because it is one of the commonest disease we see in the world. We always say
Could
that
every-
this is caused by the degenerative changes
然后
of
这
the
个人
bone and ligamentous spine.
我知道他是印度，
I'm sorry. Let me mute some people here.
可能是
Okay.
印度。
Okay,
Some,
there we go.
some,
Yeah, everybody
okay.
mute that's not speaking, please.
it's okay now?
Yes,
印
this
度
should be fine.
Yeah, basically, you know, the cervical spine goes in for some degenerative changes in the bone and also in the ligamentous spine. And that causes the symptomatic dysfunction of the cervical spinal cord. So this is the basic, what you can say, the explanation for the word cervical spondylotic myelopathy. Now, we see this very common in our practice, degenerative disease, particularly of the lower and mid cervical vertebra of cervical spine. It narrows the spinal canal and the neural foramen. And
Excuse me,
that's
Dr. Partharan, did you want to present the PowerPoint? The PowerPoint's not up yet.
The PowerPoint is there?
No, it's not up yet.
No, I'm working on that. I'm able to see that.
Okay, we can't see it though.
No?
Could you go
Parthy,
through?
you need to screen share.
I did that.
No, but you have to do it again because you got off it. 'Cause,
Okay, right.
okay.
Okay, now,
We'll get it. There you go.
all right.
There you go. Just make it big.
Yes. Now we can see it.
Okay, right, fine.
You,
So can you switch off this, my one which is on the right side? John?
yes, that's what, that's fine.
Yeah. So no, I'm seeing all of you on the side, on my right side. Yeah,
Okay, that's okay. We'll see the screen big, big.
fine. So this is basically the symptomatic dysfunction of the cervical spinal cord caused by degenerative changes of the bony and ligamentous structures of the cervical spine. That's how the explanation for this title is given. We commonly see this in our practice every day. We in our practice we see this kind of patients, and basically, you know, it comes from the lower cervical spine or the mid cervical spine. C4 to C7 is quite common, and sometimes you can see that the diffuse involvement in very old patients, elderly patients. And often we find that there is an hypermobile segment at C3 and C4. It's very interesting to find that kind of experience in our series also. But usually the cervical spondylotic myelopathy is seen above 65 years. But we can't say so, but commonly it is more often seen above 60 years age. Now, this is the basic structure of the spine and the spinal cord at the cervical spine. You can see the nucleus pulposus, you can see the lamina, spine, and the spinal cord very nicely placed in there. Everything looks fine. So this is a very nice spine and it is a normal spine. Now, when the disc prolapses on one side from outside the annulus, and you find it compresses the nerve roots, and that causes the radiculopathy. So radiculopathy, this is basically we call a cervical radiculopathy, and it causes pain and weakness or reduced reflexes that follow the path of the nerve that comes from the neck region. So are you able to see the basic picture of this? So this is the cervical disc prolapse. Would like to talk to you about maybe in some other day about this subject separately. But what happens in cases of myelopathy, you can see the disc is bulging out very large and compressing the spinal cord, pushing posteriorly. But at the same time, the degeneration also occurs at different areas, especially the facet region, and the ligament of flavum starts buckling. So when it starts buckling, you have a posterior compression too. So the spinal cord gets compressed in all the sides, so from anterior and also from posterior side, and thus producing the symptoms which we are going to see later. So the basic pathophysiology is that there are presentations which are acute presentations sometimes and chronic presentations sometimes. The chronic compression usually goes for a long time, and it causes some ischemic changes in the spinal cord, more in the anterior than in the posterior. And due to the biomechanical changes, there is always a stretch which is associated with movements of the spinal cord get caught inside the spinal canal, and there is always a stretch over that area where there is a compression. I'll show you. So this is in the chronic presentation. But at the same time, this can also be like an acute presentation in a short, for example, a subacute disc prolapse with the degenerative spine, which is already there. And they can also produce the compression of the spinal cord, the nerve, and also the artery. So this is the basic pathophysiology, how it damages the spinal cord, the degenerative spine. Now you can see in the middle the center, you see a diagram which shows the spinal cord is very, very free inside the spinal canal. And in the flexion and extension, it has enough space. And so it never gets compressed at all. It is quite free. But if you see if there is going to be a degenerative disc at one level on the left side, on the left side of the screen, if you can see on flexion, you can find the spinal cord getting rubbed over the degenerative osteophyte of the disc. So this started causing a problem both in the compression way and also by compressing the blood supply of the spinal cord, and thus reducing the symptoms. Now on extension, when the spine extends with this kind of thing, you can see the posteriorly, the ligament of flavum can buckle, and so you get a pincer effect, both from the front and also from back, that is from anterior and posterior, the spinal cord get compressed. So this in the dynamic movement, it starts compressing the spinal cord, and the spinal cord starts getting bad and worse and with degenerative changes. Now this is a very classical pictures you can see here with the osteophytes and the buckling of the ligament, whatever I said. The repeated and constant compression of the spinal cord produces some ischemic changes, which in turn leads to irreversible neurological deficit. So this is very important. So there are some reversible deficits, but some becomes very, very irreversible. That means we are going far as far as the neurological status is concerned. I'll be talking much about the treatment part in my second class, maybe day after tomorrow. Now, so the important point is about the vascular insult. How the vascular insult, like you saw in the previous diagrams, you can see the anterior sulcal artery getting compressed from anteriorly. It causes a perfusion. It causes compromise the perfusion of the arterioles at those levels. Not only at those levels, sometimes you find these blood vessels are getting kinked, and they produce ischemic changes at a far level also. And posteriorly also, posterior compromised perfusions in the intramedullary branches of the central gray matter. So the combination of these effects produces very, very severe neurological status. You can see it in the comment. Now, having said, talk about something about the pathophysiology, there are some clinical features which we commonly come in cervical spondylotic myelopathy. These are the basic, the four important cardinal things. One is the pain, the numbness and paresthesia of the upper lip, spastic of the leg weakness, and separate or in combination of a varied combination we find. So this is very, very a complex disorder. It's not very straightforward. You know, it is. This is how it is going to be. Now, here you can see the pain. The pain not only on the radicular pain, but you can also have a neck and the shoulder pain. There is a restricted range of movement in both flexion and rotation in many patients. And when the patients are more than 50 years, you can find the abnormal radiology in about 75% of the patients. So I will come to the radiology part a little later. 50% of them are either symptomatic or asymptomatic. So this is most interesting of all in this subject. And isolated Babinski is very, very significant. This clinical examination comes a little later. So you can see the diagram on the left side of the picture. I have made some lines and we will ask the patient to draw by himself, not by ourselves. We'll ask him to draw. This I always used to call it as it's a mapping, the mapping of the limb. And once we do this kind of mapping, this mark stays there for a long time until we finish our clinical examination. So in clinical examination, I advise just not to say that where the pain comes from where and where it goes, or where is the numbness, or where is the sensory changes. You can ask the patient to draw diagrams on his own arm, and it will be there forever until we finish the complete examination. So there sometimes patients have some discomfort while elicited by coughing, Valsalva maneuver, and neck extension or flexion. Sometimes you have a Lermit sign. And this is very classical. I always ask some patients, and are you okay? And I'm okay, sir. But then when I cough and sneeze or something like that, I get uncomfortable feeling in my arm and also in my chest. So that is one sign that the spinal cord is getting very, very uncomfortable within the canal. And then there will be paresthesia of the distal limbs. We'll be having a vague sensory level at clavicle in advanced stages. The posterior column, if it is getting involved, you will have a tapetic gait. I'll come to that later. So there is a combination of, it is not a very classical, it is not like a radiculopathy. In the radiculopathy, you know that it distributes here, but in myelopathy, cervical myelopathy, you have a complete combination. It is like a mixture of various sensory symptoms for the patient. You should be very careful in eliciting those symptoms and also the signs. There are some unusual sensory findings like asymmetric sensory symptoms. On one side it is more, on the other side is very, very less. Sometimes you have a brown sequard kind of symptoms, and very rarely you have a facial symptom. Some patients used to say that I have some pain which comes in my neck and also goes up to the face, but I'm not very sure. Maybe because of the compression of the trigeminal tract, which descends down sensory fibers. Some patients also shows that only lower limb alone there is a paresthesia and upper limb is okay. So we are not having a very strict guideline here. There is no guideline that this is what cervical spondylotic myelopathy means. It is this way. It is not so. It can be many ways it will present to us. And then we come to the muscle weakness. See, muscle weakness are very, very characteristic of myelopathy. So we have to be very careful. These patients which now I'm showing here, it looks a little bit more advanced. They have a weakness of the small muscles of the hand. Sometimes you find the empty snuff box. So these are very, very characteristic. And here we have to be very careful. Are we going to miss any neuromedical conditions. So those are the differential diagnoses which come in our mind. Go through that, but you carefully watch this gentleman on the left side of your screen. You find, and he's finding difficult to unbutton the shirt, and you can see the fingers. The finger on the left finger is able to hold, but the little finger is absolutely not coming in group, and the same way on the right hand fingers also. Similarly, in this lady, you can find the fingers are slightly separated, and there are very subtle signs. I'll come to that about the subtle signs. The other muscle wasting, one has to see about this infraclavicular wasting, supraclavicular, infraclavicular. You see the patient in all the sides. You have to examine the patient very nicely and see every muscle. You can see the bones are very well seen here, and he finds very difficult shrugging, very classical of deltoid and biceps wasted and weak. These are some of the extreme conditions of myelopathy patients. And these patients are, they have a very severe neurological status. It must have been going for a very, very long time. Now, this one finding, I like it. This is a very important finding. It's a very early finding, and it is a very subtle finding. We call it clumsy hand tapping sign. You have to tap, ask the patient to tap like this, and you find one side is becoming slower, the other side is faster, or both are not synchronized. They are not perfect like this. Now, if you can make it about 15 to 20, yes, you can make it in a minute, 15 to 20. But if the patient is not able to do that much or less, and he is not able to do well, so that means there is a very early sign of myelopathy. So this must be classical in this case. You can see in this man, you have some scar there in the midline. So he had a minor injury somewhere, and then subsequently he had this problem. So some of the clinical findings are very, very subtle. Another finding is that you ask the patients to hold the hand like this, and you find some of the patients doing like this kind of a very, very like very gentle movements of the fingers. Now, this is a very classical finding of cervical cord compression. This is a proprioceptive, and actually it is because due to the proprioceptive defects in the upper limbs causes these movements, this subtle movements. So these are very, very early findings to pick up. And similarly, the gait. The gait is because of the development of the UMN sign at the lower level. It causes spasticity. There will be stiffness associated with weakness, and there will be unsteady gait. Sometimes they will have a toe trip, and you ask them the history, they will say, yeah, I tripped down so many times, I fell down so many times, not able to walk on unlevel, not able to walk on uneven grounds. So there will be a reduced ankle mobility along with the toe trip, and they may be having a hypertonia, hyperreflexia, Babinski signs, which I'll come a little later. Those are the signs. But these are combined with when it is combined with the worsening, along with sensory ataxia, it is very, very pathetic to see this kind of patients in advanced stages. So spasticity is another important clinical finding. And then the gait, I'm not able to run these videos, but you have a very, very impaired gait on the lower limbs. You find the patient having a stiff leg when they walk. They have a very small walk, a very short walk, and you find they are not able to walk very freely. The arm movements are very, very restricted. So those kind of gait is very classical. When the patient enters in your clinical room, you find them very classical. They have spasticity. So the gait is also impaired. The gait get impaired because of two reasons. One is spasticity. The other one is also a combination of the sensory finding. So these two are very interesting, and you have to be pretty careful in examining these patients. And as we all knew the surgeons, and we must do the reflex examinations. I like these two reflex examinations. So one is the finger flexor examination. If the finger flex are examined, when you tap it on the fingers and you find hyperreflexia, very classical, it immediately jerks up, and that is a very classical finding. The other one is, you tip off the your fingers and you find the other fingers goes in for flexion. So these reflexes are very classical of cervical spondylotic myelopathy and hyperreflexic knee jerk, ankle jerk, and Babinski sign. Most of these things comes out very well and subtle, except in patients who have a diabetes associated or any other neuropathy, peripheral neuropathy, medical conditions, you may not get, or very, very bulky patients, you may not get it. But majority, 90% of the patients, you can elicit these signs very well. Now, there are finally, beyond this, when the patients go beyond this difficulty, wasting, walking gait problems, they end up in having some altered sphincter controls. They may have bladder problems, hesitancy, and precipitancy of micturition. There will be severe locomotion limitation, and sometimes they will have a sudden deficits on trivial injuries. So this is how they end up when they are either they are not taking care of themselves, or they're not seeing the doctors, or they are on a medical line of treatment, or if they are not protective. Now, this is you can see here is a patient who is on the wheelchair. This patient has got spasticity, weakness in both lower limbs, and also there is a very clumsy hand. So it's a combination. It's a pretty combination. They are totally wheelchair bound. Some patients do come with a catheter. Bladder is catheterized from some other place. They come. This is another very classical. You can see here one of the patients who had a central cord syndrome after a very trivial trauma. Now, the problem is that the small trauma, the trivial trauma, actually it exaggerates the clinical findings, adding a small injury to the cervical spine, which is already compromised, which is already compressing the spinal canal. So trivial injuries, many patients who got trivial injury, who have required paresis, carefully ask them, was there any history of their earlier consultation with the neurosurgeon? Most of them say that yes, they have been to a doctor and they found that the patient had some problem. Now, this is another case you can see here, and he also had something like a central cord. You can say that there is an injury in the forehead. This is a forehead injuries. When they come with this kind of clinical findings, one has to suspect cervical spondylotic myelopathy. So that is very important. Now here you can see another patient who had a canal stenosis, who was asymptomatic prior to that, but after a small trivial fall, he became quadriplegic. This is the worst thing. This is a very, very worst thing. And I asked him, did you ever had earlier consultation? He said yes, and he was advised for surgery by some other surgeon, but he was not very keen for surgery. And you can see the MRI picture, which shows signal changes. We'll come to the radiology pictures. There is a canal is narrowed there. Spinal cord is compressed. So a simple myelopathy becomes worse in quadriplegic patients. So this becomes very, very important for us to tell them, how important that they have to consult the doctor at the earliest for the next level of treatment. The important differential diagnosis for cervical spondylotic myelopathy, in my view, I have divided into surgical differential diagnosis and medical differential diagnosis. The surgical differential diagnosis are more easier, and we can always, we have some way we can do something for them, like OPLL, some spinal cord tumors, and normal pressure hydrocephalus patients. These patients look like cervical spondylotic myelopathy, but then when we do the radiology, probably I think we can find the different pathologies in that. The neuromedical conditions are MS, multiple sclerosis, and this is progressive form of multiple sclerosis. This is very, very, it just mimic like cervical spondylotic myelopathy, but you should be very careful in doing clinical diagnosis. and amyotrophic lateral sclerosis, and also vitamin B12 deficiency, where the patient have a subacute combined degeneration of the cord. So these are the medical conditions we have to rule out. When we think of multiple sclerosis, which quite commonly seen, they may not be having corresponding changes in the presence of the oligoclonal bands and the lesions in the optic nerve and brain. So we always check the optic nerve. We always do a visual about potential, and also check the brain for further investigation. If you have a pure spastic paraparesis, pure spastic paraparesis, and you don't have any other finding, then these are the differential diagnosis we have to be carefully taken. This is a neuromedical conditions like multiple sclerosis, hereditary spastic paraplegia, and you can see primary lateral sclerosis and HTLV myelopathy and adrenoleukodystrophy. But usually this kind of have a doubt, but these usually can be ruled out by first doing a MRI. Sometimes when you have the combination of these disorders, then you have a most difficult time in getting a good result. So the other very common problem we see is sensory neuropathy. At the very aging patients, they have a sensory neuropathy, and this totally confuses makes the clinician to confuse with the CSM, and some acquired large fiber polyneuropathy. So patients sometimes may also need a peripheral nerve biopsy. But this has to be combined with your radiological finding. As far as radiology is concerned, that the one radiological imaging now at present very sure is MRI. X-rays will show you degenerations. X-ray will show you everything. It can show you degeneration. It will show you the osteophytes. It will show you the reduced intervertebral disc space. It can show you subluxation. It can show you everything. It can show you the canal knurring. The same thing you can see in the CT scan. But MRI gives a better picture because it defines the soft tissue in the soft tissue of the spinal cord. And PET scan is now being evaluated. PET scan is being now evaluated, added to MRI for further clinical assessment. Now you can see some of the cases here. Here you can see very classical compression at mid-cervical spine anteriorly, and the arrow shows on the left side, you can see in the arrow shows there's a signal change. What interesting here is the signal change is slightly lower region, but though it is in the canal is narrowed. Now, I'm not much gone into the measurement of the canal. We always say that if it is less than 10 mm, then it is critical. And if it is 10 to 12, it is moderate, and more than is very fine. So some about 10 we consider as critical. But in some patients, we have seen patients who come for nothing, but you do an MRI, you find the canal is very much narrowed and they're nearly about 10, but still the spinal cord is pretty active. So we are not able to clearly say that 10 mm to be taken as the pinch point, but it can be added to overall picture with the clinical neurology. And you can see the axial cut, you can see the different type of compressions over there. It's very conical anterior compression, very conical anterior compression. I'm sure that it must be compressing the anterior spinal artery, because the amount of compression, it looks pretty bad. And this is another case you can see in 2008, you have this, the finding where there is a loss of lordosis, there is a kyphosis at the mid-cervical region. You can see a signal change in the spinal cord. Now the same patient comes back to me in 2012. Again, this is about near how many, 6 years time, you find the same thing. Maybe if you carefully look, the kyphosis has increased. It is the signal change is seen now better. So the patient is following the doctor. There is an increase in neurological functional capacity. So in 2008, this disc was looking pretty soft at C5, C6. You watch there on the left side and lower side, C5, C6, the disc looks very soft. Now, on 2012, that has become hard and calcified. I always used to say the patient postpones the surgery, and that becomes a big challenge for the neurosurgeon to operate on this kind of patients. So if we had operated in 2008, it would have been more easier than in 2012. But this, as far as for this class is concerned, I just stopped with only with the clinical findings and the radiological findings. So MRI is picking up very beautifully here. It shows the soft this type of disc. It shows the osteophyte it is forming, and it shows how much the canal is compressed and how much the cord is changing its signal changes. And here you can see in other axial cuts, it's very significantly compressed and very, very small canal over there. There is no space for the spinal cord in this area. Sometimes you find very amazingly, just one level there is a compression. No, you don't need to have a much level. It is only just one level. The disc is degenerated and there's an osteophyte, and you can see this canal, the spinal cord is compressed in one single level, producing myelopathy sign. So it is a single level compression. What I showed earlier was multi-level compression. And very rarely you can see here in one single level case, you find a syringomyelia which is going above. So these kind of very rare cases also we see. So myelopathy is not only comes because of the compression only at the regional level, but it can also produce syringomyelia at above. Sometimes you find some ischemic changes below and also. So these are the things which actually guides us about the prognostication after surgery. Maybe I can speak to you day after tomorrow, given the opportunity. Now, there is another case you can see very, very pretty bad in this case. You find so much of degeneration. On top of that, there is a subluxation at 4-5 level. 5-6 is very much degenerated. You can see the stepping ladder appearance in the MRI. And the spinal cord is completely tortuous and compressed. So this patient had a small injury and became quadriplegic. And we asked about this history. The patient had a history of consultation, but never went for any treatment. But this trivial injury made this patient pretty bad. And so as far as the radiology is concerned, on the left side, you can see the X-ray. On the right side, you can see the MRI. So as of now, MRI is the classical.
The screen sharing is not going on.
What?
I'm sorry
The
about
screen
that.
sharing. The screen sharing is not going on. I mean, if you are sharing the screen.
Yeah, I'm sitting.
Okay. I can see it now.
You can see it now.
Carry on.
Yeah, I'm carrying. Yeah. Okay. So the spinal cord, you can see now. So MRI gives a better radiology as far as I'm concerned. Now this is another interesting finding, and sometimes we have to be very, very careful in doing clinical examination. Here, if you see carefully, it is absolutely the patient there is no compression. You can see here in the axial cut C3 and C4, but if you find it in the MRI shows something in the posterior column, it's more of a demyelination. It's not a compression. So it's a demyelination signal change extending posteriorly at very high level. So these kind of cases can be differentiated with MR. You can see on the right side, you can see the anterior CS space is very well, except the fact that we see at 2 levels, the disc is compressing on the spinal cord. So these type of cases are very, very careful. We have to examine carefully, but at the same time, it has to be correlated with MRI finding. Now, on the left side, you can see the MRI, which shows the snake eye sign that shows a very chronic lesion. But nowadays, we are also doing the DTI, diffusion tensor imaging with MR, which definitely shows there is a changes at the compression level. But we are yet not very sure that how far we can take it as classical along with the PET scan. In the lower down, you can see the PET scan where there's a compression, and you find the change. The uptake is less because when there is an ischemia that you may not have much uptake. It is not a inflammatory card and which will take uptake. So automatically you can find in the PET scan the uptake is less at the region where the compression is. And the DTI, you can see there is a changes in the colors, and you can always correlate that with an MRI of T1 and T2 images. So cervical spondyloarteritic myelopathy is a very slow, intermittently progressive course of myelopathy, produces in a long time period relatively an unchanging symptomatology sometimes. And so it is very difficult to evaluate and do the therapy. So it's very long period, not just a short period where we can decide upon. The patient may come to you for many, many years. The natural history of cervical spondyloarteritic myelopathy, as per the literature is concerned, it is very variable and it is individualized. The patient's characteristics are pretty individualized, and so very difficult to make a treatment choice. And this part I would like to speak on the next class. The mild cervical spondyloarteric myelopathy, that is less than 12 of Japanese or the modified Japanese orthopedics, or less than 75 years, it do not worsen over time, and the intermittent improvement over a period of 36 months in mild CSM. They stay like that. But whereas with the mild and the moderate one, they slightly stabilize, but then they may progress. So these are the important final points I like to conclude. And maybe on the next class, I will go for the guidelines, management, and surgery. Thank you for your attention. So this is this first section of the class. First section, I was asked to do that.
Okay, very good. Thank you very much. Ike, are you there?
Excellent, Parthi. I mean, my interest in spine is almost nothing now, but you kept me completely there. I mean, I was watching everything. It was a brilliant class as usual, simple, elegant. We would look forward to your next class. Thank you very much, Parthi. An honor that you joining us. And I hope the spine team comprising of Paulo Pereira, Parthi, Ioannis, and Salman and Mehmet Zileli, they will take things forward with the spine. So we will learn just not skull base. We will have a very detailed, I will also learn some, me and Vlad probably will learn some spine as well. So I would ask Vlad to come ahead and start his presentation as soon as this is over, as soon as he's ready, and after some questions are taken place. I mean, Parthi can take some questions, and after that, maybe in 5 to 10 minutes, Vlad can start. Vlad, are you there?
I am. So I
Okay.
have 5 minutes.
5 minutes. 5 minutes. You have 5 minutes. You should set up your. You should set up your stuff and probably start screen sharing.
No, John must do it because it's too bulky.
Okay. Okay.
Yeah.
Okay.
He gives me the bulky work.
Any questions, Parthi?
Yeah, this is a very, actually the way I prepared is for, since you requested me to prepare you for the young neurosurgeons, and my speech contained that, the pathophysiology, the clinical features, and the radiology. Now, if you just listen to this talk, it is good enough to write, you understand the basic of cervical spondyloarteritic myelopathy. Nothing more is required. And then maybe some more you have to read because this one subject is for everyone. The senior most neurosurgeon also, even today, finds it very difficult when it is involved with myelopathy, with a canal stenosis and a diabetic neuropathy, canal stenosis with any other neuromedical condition. So you have a pretty big dilemma in operating on these patients. So this is the most important thing. That's why I give more important in clinical examination. The neurosurgeon must have two quality. Number one, he must be a very good surgeon. As we all know that he must develop the skill of becoming a good neurosurgeon. But still, if he has the best skill, but he also should know which patient to operate and which patient to select and operate. For that, he needs principally a good neurological assessment skill. Because many times we cannot be guided by someone else to say you operate on this patient. So you have to decide by yourself. One has to decide by yourself that you need to operate on this patient or not. And that can be done only when you clinically examine the patient very, very carefully and correlate that with your image. And then decide whether to operate or not to operate. If you want to operate, you want to go anterior or posterior, and you wanted to go combined surgery. So that I will do it maybe in my next class. So this first class, the first section of this class is about the basics.
So what about role of NCV, nerve conduction studies, in case of doubtful cases?
Yeah.
When we are not able to, what do they play any role nerve conduction studies?
Yeah, definitely. See, that's what I told you from the beginning. There are two things. Not only the NCV, and sometimes you can do the nerve biopsy also, peripheral nerve biopsy. We have done in few cases when we have a suspicious, because many times when their patients come with older age group, they also have diabetic neuropathy. So those patients, the sensory symptoms do not improve at all. And after whatever surgery you do, sensory symptoms may not improve. So to prognosticate and to also have a diagnostication, you can always add your nerve conduction studies.
And regarding the role of DTI, one study we have done by ourselves, that low FA values in DTI. In the
Not able to hear you well. Hello?
Yeah, we still can't hear you, Radmit.
Yeah.
Now I think you are able to hear me. Regarding the role of
I
DTI
think,
in the
please,
success
could you
trial.
please text me? We had the same problem yesterday. So let's go to the next question, please. Just text the question.
Hello?
Yes, next question or comment, please.
Can I ask?
Go ahead.
I'm Ramesh.
Sir, very, very, very noisy. Ramesh, sir?
Are you able to hear me?
Yeah, you're able to hear, but you can go behind the mic, little away from the mic.
Yeah. Are you able to hear now?
Yes,
Yeah.
we can hear.
Just I wanted to congratulate you on an excellent presentation overview about the spondylotic myelopathy. I would like to share, your views that there are a few points which need to be emphasized, because when many of these medical conditions, as you pointed out, one is this: you have to find out this subtle sensory findings. Subtle sensory findings, I mean, is the Romberg sign. It's one of the very important signs. One has to look for carefully before, excluding, trying to label it as a spondylotic, amyotrophic lateral sclerosis or something like maybe may closely mimic. And also another feature which I have observed closely, Gloven-Stocking type of sensory impairment in many of these patients having spondylotic myelopathy. Many of the textbooks try to offer explanations which are not satisfactory. And another thing is the mismatch between the sensory level and the compressive level. That also happens in early myelopathies, which is sometimes mimic the dorsal level, and many times we find a lesion in the cervical. So these are things which you have to bear in mind in a clinical examination of patients with spondylotic myelopathy. I think it's an excellent overview of it.
Yeah, thank you, sir. Yeah, I agree with you. Yeah, so sensory examination is very important. That's what I was telling. Whatever I showed, because sensory I'm not able to, but then what you said is Gloven-Stock types and the Romberg sign, posterior column signs, and they are very much important. So the clinical examination must be very, very thorough. Must spend a lot of time in clinical examination of these patients.
Okay, I'm asking Vlad to come in. Thank you very much, Parthi. We look forward for your next class. I'm asking Vlad to come in. Vlad, please start your presentation.
Okay. Do you hear me?
Yes.
Yes, absolutely.
Okay, John, you have to start the presentation.
Yeah, yes, Vlad, it's only appropriate that I say that we are going to enter into a Kafka-esque experience. Okay, let me just screen share this. I'm getting, you can't see the screen, right?
I do.
Oh, okay, yeah, let me screen share. Hold on. Not sure it's okay. I'll go through a Google Drive. Okay, now okay, just tell me where to go. You want me to start with the PowerPoint
Yeah,
or one of the videos? Or what should I do?
no, down, John.
Okay,
Go down,
okay.
go down. And this is it, an STV,
Oh, yeah,
SCIT.
that's the PowerPoint, right?
Yes,
Okay,
that's it.
yes, okay.
Can you make it any larger or not?
Let's see here. Like, is that okay?
That's fine by me. I do not know how it will be with the. That
Okay,
was better.
just lead me.
Oh, you cannot go slide by slide?
No, I can't. I've never done this before.
Because I have
But
to
he can
prompt you
do-
to show the next image.
But Vlad
Yeah,
can
well, I
see-
just go down. I just go down.
You will go down. And what
yeah.
about the videos? Will they work?
Yeah, we'll just take them one by one. Just
Okay.
you need to lead me through.
Okay, so let me start.
Oh, yes.
Yes, this is my beloved approach, you know, and I've started that sometimes in 1987, 88, first one. Then I didn't do it because I didn't see too many patients like that. But again in 90s, and the model disease was pioneer cyst. Can we scroll down? The
Okay.
pioneer cyst was the first thing which I did with that. And here is the series we are having, like 174 cases of this approach. Not only this approach, there are combinations with retroseg, with supratentorial, but not that many. More than 150 are pure supra-infra cases. Can we scroll down a bit, John,
Okay.
to see the procedures? And now up.
Okay.
Okay, you cannot put it like PowerPoint, because then you have the
But actually,
respective images.
It's an impeccable
think-
production.
John,
I think you need
Just
to download it. Download
Just
it.
Yeah,
and,
John, you need to
open it.
download it.
Yeah,
That will take lots of time to download it.
yeah, I
There are
don't
the
know.
attached videos.
I can just do it. I just do this manually. It seems that this platform doesn't
Okay,
have an easy.
let's do it like that.
Yeah, unfortunately, it's all by
well,
hand. Okay.
Okay, so let me continue. But you see that besides pioneer cysts, there slowly appeared lots of meningioma. That is the main bulk, like 64 cases. Part of them were CPA meningiomas, but the main number again is PC meningiomas. Then there are these incisural and anterior rectus sinus meningiomas, not that many of them. And the big issue are brainstem cavernomas, which are really great. Either pons or mesencephalon or thalamus. I will show them to you later on. Of course, some gliomas, pilocytic. We do not see too many pioneer tumors, but still there were 9 of them. And then going down with cholesteatomas, cysts, ependymomas, peanuts, fifth schwannomas, and then single cases like plexus papilloma, hemangioblastoma, ABM, colloid cyst. So whatever you name it, you can do by this approach, provided it's in the region of supracerebral approach. Let's scroll down. There are many cases you do not need to operate, especially in the cyst. You see a huge cyst, then half a year later and a year later, everything disappeared. So only the growth or clinical symptoms lead you to surgery, not only the presence of the lesion. Next, please. Can we scroll?
Yeah.
So model disease is the pioneer cyst. And let's go to the video, what it looks like. What I started first was the midline approach. John, there's a video.
Okay, I have to, okay, let me get off the screen. We gotta share. This is a little onerous, but oh boy. Sorry,
Oh
folks.
boy.
Yeah,
Does everyone have time for till tomorrow?
No, I'm sorry about this. Oh man. Okay, forgot about that. Screen sharing stopped. Okay, let me go to square one.
John, relax.
Relax,
Yeah,
John, don't-
yeah. This is, let's see here. What do I want to get? I want to get to the link. Okay. Okay, let me go here. Okay. Okay. I'm gonna screen share again, Vlad,
Yeah.
and yeah, we may have to figure out a better way to do this. Okay, you can see the screen, right?
I do.
Okay, which video? Hold on.
Try to find something with pineal on it. That should be it.
Okay,
Pine
Which fi-
cyst one. Pine cyst one. Go. No. Stop. Pine cyst one.
okay. Impeccable production.
Yeah.
Okay, oh my God. Processing this video. Okay, download now. Oh my God. I'm sorry, we didn't see here the download it. Yeah, okay.
While he's playing the other ones, you can start downloading the other ones, John. No problem at all.
Yeah,
Absolutely.
No problem. But
the flat file we can't play.
what?
I
do
don't
you
know
that-
why. I don't know why.
John, do
can't-
you have the PowerPoint on your computer?
Yeah, but it's a separate file. I have to change screens, etc. So,
Okay.
If you would,
Okay, 1 second. Vlad, do you have these videos in your computer that you're talking right now?
yeah, I do.
No, he has low bandwidth.
But
Like
we
you can't
tried that,
upload it. Ike, you
I
have
cannot
you,
get through.
you have the link, Ike. You have the link of the videos.
No.
Can you do it?
1 second, John. One
Yeah.
second, John.
Yeah.
Vlad, if you can screen share, you can start showing these videos by
No.
yourself.
We tried that with John, and my connection is weak.
Yeah, the
So
bandwidth
that
low.
doesn't go through. We have tried that.
Yeah, bandwidth low. You have the
It's
link,
okay.
right? The link I sent you for Vlad's. I can
Vlad,
resend it
unless-
if you want. I can resend the link to you, Ike.
Let me see.
Yeah, hold on.
No, but Vlad, try screen sharing. Let's see if it works. That will be the best.
I can't. You cannot start screen share while the other participant is sharing.
Yeah,
Okay.
and plus the bandwidth type is just not good enough. It doesn't download anything.
So why don't we go without videos?
Oh,
No,
whatever
no.
you, hold on. Okay, hold on. I'm gonna give Ike the
Go
link.
back to the presentation, John, and we shall go without videos. There are images, still images, which will show almost everything
Okay,
later on, and we shall skip the videos.
okay. Okay, let me go to the,
And later on we can try to find a way, and I can show the videos some other time.
Yeah,
What do you
yeah.
think?
yeah, it's a good idea.
Yeah, absolutely. So Vlad, you're going to have a lot of classes, Vlad. You're going to have, I mean, we need to see this approach, what you
we
have.
need, we need to find a connection with John, you know, that.
What I will do is, Vlad, I will download all your videos and I will share it for you.
Good.
Okay.
That's a good idea. I will send it to you via cloud. You will download it to PowerPoint and give it to John. Is
Yes,
that an
absolutely.
option?
Yeah, absolutely.
Okay, let me screen share your PowerPoint. Oh, okay. Okay.
Okay.
Okay. You
So
see it?
let's go through the Pioneer, through the videos. Now there were two. Go down, John, please.
Okay, down.
Down. Okay, stop. This is the video actually, but what you see from the midline, just in the middle of the screen is the vein of Galen, and then both ambient systems. The arachnoid here is always very firm and very dense. You do not see through well. And just behind the arachnoid, what you encounter are the big veins, both Rosenthal's and internal cerebral veins. You should preserve them at all costs. So it means that the dissection should be sharp. Cutting, knifing, whatever, not tearing arachnoid like in other places everyone is accustomed to. Do not dissect their usual way. Do it sharp. Go down, John.
Okay.
Okay, now this is at the end of surgery, and you see the big veins on the side of the screen. One of them is Rosenthal, the one in the midline, or more to the midline, is internal cerebral vein, and the dark space in the middle is the third ventricle. What the forceps is holding is the pineal cyst. There is the only vein which should be preserved coming out of the cerebellum. The vein is very tiny, and it's called the cerebellomesencephalic vein. You can push it on the side, but do preserve it. I never sacrificed it, so I do not know what the consequences may be, but this is the one which is said to be preserved. Next, please, John. So technically, you can use it in two ways. One is a median, like medial approach to pineal region, which is anterior. You go up to posterior third ventricle, ependymoma, for instance. Then superior, even more, then you have to cut the tentorium and you get to the posterior thalamus very easily. And then you can go down to the fourth ventricle, provided you either push the cerebellum down or you may make a small cut in the paravermian cut in the cerebellum. Or they are the same approach. We now are using only unilateral approach, no midline at all. You can go either to the apex of the pyramid, you can go to the upper tentorial edge very easily, or you can go medially and inferiorly to the clivus. All these tricks are possible, and you have enough space provided you have prepared yourself well. Go down. So how we do it? Always sitting position, because then you use the gravity for the cerebellum, and the sitting position with our anesthesiologists is not really that dangerous. There were some cases of air embolism, but only one of them ended badly, and we do quite a lot in sitting. CSF drainage. For the beginning, you need to drain some CSF. The best is lumbar drain, because if there is a huge tumor, like petroclival meningioma, then the cerebellum would not allow you easily to go get above that. If you drain some CSF at the beginning, then the cerebellum falls down, and this is because you do not enter the CSF spaces at the beginning. You enter them only later on. So some kind of CSF drainage. Craniotomy should be well above the transverse sinus, because you lift not only dura but also the sinus, and any millimeter which you gain in space is very helpful. Dura, U-shaped incision along the transverse sinus and only 15-20 millimeters below, not more. If you cut it lower, then the cerebellum would prolapse out of the approach. So it should still be covered by the dura. Don't open it too extensively. Several stitches to lift the sinus, and you lift the dura, you lift the sinus, and you even can put stitches into the tentorium to gain again another space. Not much, but still you need it. Then you can cut the tentorium along the rectus sinus, and laterally you go along the superior petrosal sinus as much forward as you need, and the limit is the entry of the fourth nerve into the cavernous sinus. And it's actually a convexity approach for skull-based lesions, as we shall see later on. Go ahead. John?
Yeah.
Okay. So,
That's right.
back. That's it. The main indication for this approach are the lesions which are below the vein of Galen. Once the lesion is above the vein of Galen, you should use some other approach, like falcotentorial, transtentorial, whatever. You see here the color, it says in the posterior third ventricle, and it's above the vein. So the approach on the right hand side, it's after surgery, was through the falcotentorial, supratentorial approach, not infra. So the vein of Galen is the most important landmark if it's above or below the lesion for the midline lesions. Next, please. So what you can all approach, you can approach upper cerebral hemisphere. It's obvious. You can approach tentorium, anterior rectus sinus, pineal, posterior third ventricle. Mesencephalon is obvious. It's directly in your line of vision. Upper fourth ventricle, posterior thalamus, upper CPA and petroclival, and the anterior limit, you will see it later, is posterior clinoid. And you can approach basal medial occipital and temporal area, cutting the tentorium, and suddenly you have a huge side of the lower parts of occipital and temporal lobe. Next, please. You see, this is the craniotomy, transverse sinus, and the black line is how the dura is open, not any lower. The dotted line shows when you need to combine it with retrosig approach along the superior petrosal sinus. So this extra dural cut is then used. Next.
Okay, hold on.
John?
Yeah, okay.
Okay. So this is the model for this approach. It's cavernoma of the quadrigeminal plate directly in your line of vision. Go low. You see the approach here on the images. John,
Go down a bit more low.
go down
John.
a bit.
Okay.
Okay. You see, this is the approach at the beginning when some of the CSF is drained, and on the right image, it's the approach at the end of surgery. And you see that the space you gain between the tentorium and the cerebellum is pretty wide. And the only thing, if you are going to pineal lesion, you need longer instruments. Next, please. This is the cavernoma already, and after the resection of the cavernoma, go down, up, down a bit. And you see that this is the Roton's book, the pineal region, and this is from our surgery. It's exactly the same. So it's beautiful anatomy. This is what I plus always when I give this lecture. And you see all the vein, internal cerebral veins, basal vein of Rosenthal, vein of Galen, all the nerves which are there, which is fourth mostly, which is lowermost limit of your approach, is the fourth nerve. Next. And this is what I told you, what is the anterior limit of the approach. Here is the cholesteatoma, which provides you space. And you see on the right hand image that you see the third nerve, you see the superior cerebral artery, you see the posterior clinoid process, and the anterior limit is the Lillienquist membrane. You, of course, can go through, but there is no point in that usually. So this is what you see at the end of surgery, say in the petroclival meningiomas. Next. Pontine lesions. You see the cavernoma within the pons, and the red arrows directly show you where you need to approach your tentorium. You are underneath the tentorium and you are on the lesion. The only problem in this region is the lowermost part, which is difficult to approach. But in cavernomas, this is easy. Next, please. This is day after surgery. Next one, we shall have see the next. Again, the only thing you need to either retract or approach is the red circle, this tiny part of cerebellum. You just push downwards and you are on the upper part of the pons, and you can resect this cavernoma. Next, please. That's it. Next. And this is posterior ventricle ependymoma. You see it on the sagittal image, that it really is in the third ventricle. It's below the vein of Galen, and underneath you see the post-op images. The only thing really is the long instrument. John, can we go down? This is after. Next, please. Go down. This is the AVM in the superior colliculus. It bled. You see the angio. Here is the selective angio, and our endovascular people were afraid to embolize it because there is one tiny perforator which probably was en passage. I don't like gamma knife for brainstem lesions, so we went ahead with surgery. Go down. This should have been videos, but we can have them on some other day. This is at the end of surgery. Go up, a little up. And you see that all the perforators were preserved. The black part between the forceps was the bed of the AVM. The only trouble here was that it was completely against all AVM rules because we went along the vein, cutting all the vessels going into the vein, because finding some feeding vessels was outright impossible. Next, please. This is post-op image. The AVM is out and the patient is doing well. He surprisingly doesn't even have diplopia. Next. And this is the case of upper fourth ventricle. Of course, some people would approach with Teloverl approach, but it's still far, and you need quite a lot of retraction to get that high into the region of aqueduct. So let's go down. These are videos, but it doesn't matter. You see up. This is the mesencephalon, the whitish tissue, and you see the simple cerebellotomy paravermian which we will perform. Next, please. This is the cavernoma within the fourth ventricle with this simple cut of the cerebellum. Next, please. And this is at the end. Sorry, I got a phone.
Hope that's a technician.
No. Sorry, this was my phone. And you
Okay.
see that you have to present. That was yesterday. You was presentation. He didn't talk about the veins, but all these brainstem cavernomas do have some venous anomaly, and you have to know about this anomaly in advance and preserve it. So here there were 3 veins. You will see another case with lots of veins in the vicinity, and that's probably the most important in cavernoma surgery of the brainstem. Next. And this is post-op image, and you see the little tiny cut in the cerebellum. That was all we did, and no retraction, no nothing. Next, please, John. And this is the case where you need to cut the tentorium. The point where you need to get is the space between the temporal lobe and the midbrain, where the posterior cerebral artery runs. And directly at the side of the posterior cerebral artery, you see the yellowish tissue of cavernoma, which you may resect. But here in this case, it really is necessary to cut the V-shape incision in the tentorium. We will see it later in a meningioma case, how this is done. Next, please. Video, doesn't matter. And this is the frequent criticism that you need to operate with your hands elevated, hands up, which is really unpleasant. Not true. This is above the tentorium, exactly the case you have seen. And you see that I have my arms perfectly horizontal on the armrest. The only thing, as Ibe has said at the beginning, you need to have longer hands. If your arms are short, you will not get there because you need some space for your microscope and you need to have long instruments. Next, please, John. This is the lady after the surgery, the cavernoma case. You see where we were. Next, please. Oh, what is this? Oh, this is the case which doesn't belong here. This is the case for retrosic approach. It's at the level of the 7th, 8th nerve. Go down. And you see that we approach this cavernoma. It's well seen here, the cavity, the basilar artery. The nerve which is closer to basilar artery is the 6th. Then there is ICA, and then there is 7th, 8th in front of the picture. Next, please. Go down, go down. This shouldn't be there at all. This one, next. That's it. Another ependymoma of the posterior subventricular pineal region. Go down. Down, John. That's it. That's after. Perfectly clean. Go down.
Okay.
Okay. This is the pilocytic of the thalamus, and again the same approach, cutting the tentorium and going directly to the tumor. Let's see the post-op image, which is underneath. John.
Okay.
That's it. And this is the late control after 2 or 3 years. And you see that the tumor is completely out and the patient is doing well. We can go forward. Well, this was a strange case. This is a meningioma in pineal region, and the tumor was not attached to dura at all. I do not know where from it grew, but simple, easy, fast surgery. It was like the tumor was nearly free getting out. The next case, which is just here underneath, this is a 33-year-old lady who is 6 months pregnant, and she deteriorated, as it happens with meningiomas in pregnancy. So we had a lot of discussion with obstetricians, and they said, all right, do your surgery when she's still pregnant. You see on the right side down there is the post-op image. And let's see the surgical image. This should be video, but doesn't matter. The nerve in front of you is the third nerve, and then there is the Lilink with membrane, and the fifth nerve is somewhere underneath the suction tube. Everything went well. We had to leave a piece behind in Cavu Mekeli because the obstetrician told us quit because the kid is not doing well, and go down. And this is the patient, and this is the kid who spent some time with us in the OR, and the only sequela on the right-hand picture, you see that the father started drinking, but otherwise everything went well. Next, please. So this is the summary what we can approach. Next. This is a, no, this doesn't belong here. Go down. This wouldn't show up in a PowerPoint. Go down, go down.
Okay.
Okay. Next, next.
Next.
Next. This is another tumor. Next,
Okay.
which is in, but this not this one. Stop. Go up. And here you see the pilocytic astrocytoma in the thalamus, which has a cyst, and the cyst is reaching the pineal region. So that's exactly the point where you need to approach it. You can go either ipsilateral or contralateral. It doesn't matter. Go forward. Next, down. And this is the approach. The knife is cutting the arachnoid in the ambient system. Then piece of the tentorium. This is video, but we can see it some other time. A little V-shaped incision in the tentorium, dissecting the peduncle a little higher up, and then the incision. Next. And this is the tumor seen through the cyst. Cyst provided the space for tumor resection. Next, please. This was the epidural after surgery, which happens. Shit happens always. Next, please. And this is the post-op image. You see that everything's perfectly clean, perfectly out. Next. And here's the patient who is perfectly well, doing fine. And it's like 5 years now. Next, please. This doesn't belong here again. This is something else. Next. This is skiing. Stop. A little higher up. This is a little kid, males, 8 years, and he's got biopsy. Elsewhere, they said pilocytic astrocytoma. For unknown reason, they gave him chemotherapy. And then he came to us with upper extremity tremor. And you see the tumor, which is quite high up, again, pilocytic astrocytoma. And I saw that the tentorial cut will be needed in this case. Next piece, it was not. You see, this is the cerebellum, this is the tentorium at the upper part, and there is the fourth nerve and the superior cerebral artery, and just behind it is the tumor, the peduncle with the tumor. Next, please. During the resection, all the tiny arteries must be preserved. Next, please. The CUSA is the best instrument to resect it. You see the perforator, which is circumferential perforator of mesencephalon, which was running around the tumor and even within the tumor. So this is the vessel to preserve. Next, please. This is at the end of surgery. Next. This is the approach. You see at the back of the image is the mesencephalon, which was cut, and you see the superior cerebral artery up. Next. And this is the post-op image, and you see that there probably are some remnants in the bottom, at the bottom of the cavity, which is exactly the spot which cannot be reached by this approach, because you cannot retract the cerebellum that much, and you wouldn't like to retract the mesencephalon to get inside. This is the kid after surgery doing perfectly well. Next, please. And now we are at the meningiomas, and here will be all the anatomy. This is the petroclival meningioma, which is growing subtemporally a bit, which is in cavernous sinus and cavo mecali, but most of the tumor next is in the petroclival region. Next, John. Next. Here you see the tumor. It's not really a big one. Excuse me a minute. Maro, zavoláme za chvilku, jo?
Hope that's a video, guy.
Yeah, that was about the tennis, which I cannot miss today. So next, please. And these are the steps in surgery. First, what you resect is the part of the tumor. You undercut the tumor from petrosal sinus, which is the green circle. Then you cut the tentorium, such a V-shaped incision, red lines, and then going subtemporally for the piece of the tumor, and later on into the interpeduncular cistern for the rest. And now let's go through the images, what you see. It's beautiful anatomy. So this is the beginning, cutting the tentorium. Next. Here we are at the bottom of the tumor, the lower part. Immediately anterior is the 7th, 8th, then ICA, then the 5th. Go forward. Then we see 5th and 6th nerve at the midline or medially, and the tumor is lifted and dissected free from superior petrosal sinus. Next, please. This is the most important nuisance, is the 4th nerve, which is running directly posterior to the tumor. And these tumors usually are not in one cistern only. They encompass several cisterns. In this case, it's cerebropontine, perimesencephalic, and interpeduncular. So all the arachnoid layers must be cut and go through. And to preserve the 4th nerve is nearly impossible in these cases. But fortunately, even the damage or sacrifice of the 4th nerve is perceived by the patients very well. Next, please. One would say unimportant nerve. This is a superior cerebral artery, which goes with you all the time throughout the surgery. You all the time see it coming towards you. Next. And this is what you see at the end when you resect the tumor in the interpeduncular cistern. So this is the opposite side of surgery. It's the optic tractus, pituitary stalk, P2 segment of the posterior cerebral artery, and the posterior clinoid process on the opposite side. Next, please. And this is a little better seen, the tractus and the pituitary stalk. Next, please. You could resect pituitary adenomas and craniopharyngiomas by this way. And this is ipsilateral. This is the 3rd nerve. This is the superior cerebral artery, the peduncle on the right side. And again, the opposite side, the ipsilateral posterior cerebral artery and ipsilateral posterior clinoid process. Next, please. This is the 3rd nerve again and superior cerebral artery running towards us. Next, please. This is the basilar arteries, posterior cerebral artery and superior cerebral artery. The typical thing, the only stable anatomy that the 3rd nerve is between these two. Next. And this is at the end of surgery. You see the cavity after the tumor in front of you, and you see the V-shaped incision in the tentorium. That was all which was needed for this surgery and surface of the cerebellum. Next, please. This is the post-op image, and you see that only remnant we have left behind is within the cavo mecali. Next, please.
Please mute.
Huh?
Okay, go ahead, Doug.
Okay, go ahead, John.
Go
Oh,
ahead.
someone wants to ask a question? Sounds like
Okay,
Sherian Jr.
go ahead, Vlad.
Go ahead. So scroll down, please.
Okay,
Next. We shall skip this. This is another petroclival meningioma. And these are the petroclival meningiomas which were approached via this approach. There are some of them sphenopetroclival. There are some like Petrosapec. It's confusing the terminology. The only thing is that they are anterior to the nerves. That's the feature of petroclival meningiomas in my mind. And anything which is posterior to the nerve, mostly fifths is the landmark. I call the CP angle tumors. Go ahead. John?
forward.
Forward.
Sir, once please
And these
repeat it.
tumors which look alike
Anterior to-
are CP angle. Next, please. This is the petroclival tumor where the supra-infratentorial approach is not enough, but it's a combination of supra-infra, retrosic, and even far lateral, since the tumor grew as far down as the. Let's go forward. You can see videos. So,
Yeah, it's the Wi-Fi. You just hang in there.
doesn't work anymore.
Yeah, we can hear you, Vlad. Go ahead.
So okay, so if you can go down, just skip this case. This is the beginning. You see supra-infra approach at the whitish tissue, which is vertical, is the fifth nerve, which run up and down, downwards. This is the seventh, eighth, and still the tumor is there. Next. And this is like far lateral. This is the 9th and 11th, and the remnants of the tumor in between. The origo of this tumor was in front of the 7th and little lower, going down to 9th and 11th. Next, please. These are the tumors which are in the rectus sinus or falcotentorial region. Again, approach via this, but quite frequently some supratentorial approach is needed as well. So you may start with supracerebral infratentorial or with suboccipital, whatever. Next, please. Next, the same thing all over again. This is an interesting case. This is a young lady who came to us and she had fatigue disturbances. She already was rather symptomatic. You wouldn't like to approach this meningioma from supratentorial because you would need some retraction, which definitely would harm the patient because we are on the dominant side and you see the edema. So this is beautiful case for supra-infra approach. You just cut the tentorium, thus you treat the tumor origin, no bleeding, no nothing, and you resect the tumor from supracerebral root. Next, please. These are the images after surgery. You see the nice cavity and the lady doesn't have any neurological problems. Next, please. So overall results, which is important in these 174 cases. I do not have the detailed analysis yet. I just collected them now thanks to coronavirus. I had some time to check the files. So Gosset, 8, perfectly well patients without any deficit was 72%. Altogether good recovery with some minor deficits like fourth nerve, like some fifth nerve numbness, things like those which are not deteriorating the quality of living. Altogether, it was 92%, which is just fine, with which I'm satisfied because unlike many others, I do have some complications. And the complications appeared in 7.4% in 13 patients, which were severe complications. Out of these 13, 6 patients died. I don't believe that you can avoid complications in this region. I don't believe that you can treat all the patients without mortality in this region. Next, please. Let's see what those complications were. This is Gosset 1 through 4, altogether 13 patients. There were 7 petroclival meningiomas. One of them was a lady which we attacked from above, from supratentorial for the supratentorial part of the tumor, and she got air embolic stroke. So she was hemiplegic. We still operated on her after that. The next case, the pituitary adenoma relapsing, it was the most unfortunate and quite recent case when I sacrificed 2 veins coming from cerebellum to the tentorium, and this ended up with severe cerebellum infarction, which we were unable to control. One upgraded glioma died later, not immediately, but some 3 months after surgery. 2 pineal tumors died. Whether we helped with surgery or whether it was a natural course of the disease, I don't know. One ependymoma grade 3 died, and one relapsing chordoma died 2 months after surgery. The causes of these complications were technical in 4 cases, either vascular or these veins I told you about. There was one air embolism and stroke. There was one unexplained thalamic bleeding. I will show it to you. And the rest 7 patients were those who I call too much too late. Patient who is of higher age, with many concurrent diseases, and who deteriorated. The patient who comes to you with a huge tumor with Glasgow, 8 on a ventilator, you cannot refuse surgery, but you cannot expect a good result. So these patients were 7 of them. Let's see the disaster. Next, John, please. You see, this is a pretty simple CPA meningioma. Very straightforward, very easy surgery. Next, please. And the lady did well for 2 days. On day 3, she deteriorated, and you see the thalamic bleeding. No explanation in my mind. Next, please. And that is the end. Again, just to summarize what we can approach. CP angle, pineal, upper force, posterior cell, posterior thalamus, posterior clinoid, and inferomedial regions of occipital and temporal lobes. Anything above the meatus and anything below the vein of Galen. Next. And that's the last take-home message from this lecture. Be flexible and inventive. Don't be dogmatic. View the approach to the lesion, which is important. Not the lesion, not to the approach. This is beautiful what Juha is using the term inaflateral. Exactly tailored to the lesion. And this is the same case. Thank you.
Okay, a Kafkaesque present. Thank you, Rod.
Yeah,
Okay.
Thank you, John. Thank you.
Okay, now
You
I
have
know
learned a
what,
lot, didn't you?
well, now I know what it's like to have a burst aneurysm. Okay, Ike, are you there?
Let him in. He's not in the panel yet.
Oh, okay, yeah, I had to pay attention to the presentation. Yeah, any comments or questions till we get Ike back in here?
Hello, dear
Oh.
John.
Go ahead, Victor.
Victor. Hello, Victor.
Congrats, dear Vladimir. Too many cases. I think the supracerebellar technique is not an easy technique. You should be involved with anatomical landmarks, as you have said, because damage of the vein deep system could be very dangerous. Congrats.
Thank you. Thank you. The landmarks are 2, actually. The big veins in the midline approach and the 5th nerve in the lateral approach. The 5th nerve is affected in almost all meningiomas, and the most frequent post-op complication, minor complication, is the 5th nerve numbness. And 4th nerve, it's quite frequent sacrifice.
Can we try patient in prone position if we don't have monitoring instead of in sitting position? Can we try in position in prone and concord positioning and try for pineal tumors this approach?
Yeah, You were asking first about the monitoring and then about the position. Monitoring.
If suppose monitoring is not 2D, meaning the echo monitoring is not available
I
for
see
the
what you mean.
embolism.
Well, we are having catheter in the heart, and our anesthesiologists now are having some special machine. It looks like rain, you know, and you see all minor bubbles running there, really micro bubbles. So they warn us immediately if something's happening, and we then not close the wound, but we are seeking the origin. So the monitoring of the heart during sitting position is extremely important, and you really need to have a good anesthesiologist who balances the pressures and everything. Still, you cannot avoid all the problems, but as long as they are not clinically significant, it's not really that important. About the prone position, you are losing the advantage of the gravity. I've seen it elsewhere being done in the prone position, and then you really need to retract the cerebellum. The probably good position would be like that Concord, you know, what someone is using for schwannomas or park bench, but you would be unable to come from above, from behind the head, which is usual position of a surgeon. You would have to go from posterior, you know, like squeezing yourself behind the patient's shoulder and doing it. I can hardly imagine that. And as long as the sitting position is working for us well, we are using it. As easy as that.
Sir, can you please show one video of the midline and the lateral approach after the craniotomy? Midline, just a small video of what veins will come and how to avoid.
Yeah, I would love to, but videos are not in my hands. Videos are in the hands of John, and we must work this out together with John, and I can show it at some other date. The videos are beautiful because the anatomy is beautiful, but we can't have it now. John, next time.
Yeah, if we get to a good connection, it'll be easy. It'll be easy.
I will try it from the hospital if it will be easy.
Yeah, it's difficult times.
Here at home, we have a very weak connection, very low capacity.
Yeah, we're just doing the best we can today.
Yeah.
So, okay, more comments, questions?
What is the
that was a good lecture.
Yeah.
Can I have one question?
Go ahead, sir.
Go ahead, Rupesh.
Yeah. So what is the status of the precentral cerebellar vein? Do you have any problem coagulating these veins for any of your cases?
I don't understand you.
The precentral cerebellar vein, when you're operating through a midline supracerebellar approach, how often had you had a problem coagulating the precentral cerebellar vein?
I used to have this problem when I was using the midline approach. Once I started with this unilateral approach, you do not have a problem to avoid this. You get in front of these veins. If you come obliquely and you do not release the vermis, you do not coagulate the veins coming from the vermis, which I did at the beginning. Now coming from obliquely, you are in front of this vein. So you do not need to sacrifice it. It still holds there with all the arachnoid. You will start with the arachnoid window on the ipsilateral ambient system going upwards, and you will leave all these veins as well as this cerebellomesencephalic on the side. You do not need to handle it at all.
So you do all the cases only lateral. You don't do midline.
All of them, not anymore. At the beginning, I did all of them bilaterally from the midline, you know. But very early on, I realized that it's so deep that your angle of approach is favorable in all cases. So now for everything, we use unilateral approach only for the midline.
Oh, fine. Okay.
Well,
I have a
excellent.
question, please.
Yeah.
Dr. Najjar from Syria. I want to thank you very much for your wonderful lecture.
Thank you.
My question is for the meningioma, vitrectoclival meningioma, and the attachment to the dura. How you control it, because you are coming posteriorly to the tumor, and we know you should make a devascularization for the tumor very early to control bleeding and to continue. How can you manage?
Most of these tumors have the attachment in the region of superior petrosinus. It's really analogic to sphenoid vein tumors, these meningiomas here. So you just undercut them. You release the tumor from above, from the tentorium, where it's where it's not attached, and then you go along the tumor origin, along the petrosinus as far down and as far anteriorly as you need. And actually, you even can drill the petros apex by this approach. It's not really that easy, because in your way is the fifth nerve, and the structures are rather delicate. So I don't like to drill petros apex from this. But everything you can do with Kawase approach from above, you can do with this approach from below. The only trouble is the Kavu-Mekele, because it's flush with your approach, and you do not get that easily as from Kawase approach. It's not so easy to enter the Kavu-Mekele, but you can enter it, and you can drill the petros apex, and you can detach the tumor, which quite frequently or most frequently is originating here. So you control the bleeding. It's as in any meningioma. Devascularize, devascularize, devascularize first.
We have a question from Carlos Yumaguano, neurosurgeon from Spain. Is in falco-tentorial meningioma with SR involvement, what is the strategy?
Depends. These tumors are either purely supratentorial, then you go from supratentorial via falcotentorial angle. If this tumor has a part which is below and above tentorium, then it's really very individual. If the major bulk of the tumor is infratentorial, I start with supra-infra. If the major bulk is above the tentorium, I start from above, sometimes even bilaterally. What is the problem, and which was one of my disasters in these tumors, that the rectus sinus and the vein of Galen were occluded by the tumor. I started from above, cutting the tentorium, cutting the falx, and then coming forward, I came to inferior sagittal sinus. And in advance, I didn't realize that inferior sagittal sinus was the only drainage from the deep structures, because it reverted from the occluded vein of Galen, then to the inferior sagittal sinus. I cut it, and what it caused was like 3 months in the ICU. Ultimately, the patient ended up very well. You know, he's independent, doing whatever he wants, but being a little slow and a little dyslexic. But this is something in these tumors which must be evaluated very carefully, is the venous drainage. And the strategy then depends on the location of the tumor and on the venous drainage. But individual, there are not that many of these tumors.
One more question, can I have?
Go ahead, Carlos. Go ahead, Carlos.
Hello.
Go ahead, Carlos.
Yeah, Professor Vélez, good afternoon. My name is Carlos. I'm working in Spain, such as a neurosurgeon. What's about the pre-early studies or diagnostic studies for the venous drainage involvement? If, for example, is in a truly falcotentorial meningioma, when it's affecting in the anterior part, the vein of Galen, it's go out through the sinus rectus.
Yeah, this is
with a minimally drainage of the vein. What is the strategy? Maybe in this situation, have, for example, the angiography performed before the surgery, and to decide where, for which side or many of proportion of these meningioma can be retired.
You are perfectly right. And I can tell you that in these tumors, which are affecting the rectus sinus and the vein of Galen region, I always perform angio before surgery. Always. It's part of the regular workup. And the most difficult part is the tumor in the rectus sinus, because you are coming from either supra or infra, it doesn't matter. You are coming along the rectus sinus. And if you resect the rest of the tumor from the rectus sinus and it suddenly gets open and it flushes all the backwards blood, you cannot control this bleeding because you are orthogradely with the sinus and you cannot occlude it. So in some of these cases, I intentionally left piece of the tumor which is most posterior and which is like a cork in the water at the orifice or at the end of the rectus sinus. You always can treat it with gamma knife later on. So easily you can resect the part of the tumor which is in the pineal region, because there's a lot of arachnoid which is protecting the brain against yourself, and you can preserve the nerves. But the trouble is the rectus sinus and the backwards flow. The last piece of the tumor in the rectus sinus. Leave it behind.
Sir, which side to approach, either right or left? Suppose a midline pineal region tumor.
I don't hear you. Sorry.
Yeah,
I don't hear you.
Sir, a midline pineal region tumor, which side you approach, from the right side or from the left side? You do a craniotomy on the right side, right paramedian or left paramedian to approach a midline pineal region tumor?
Doesn't matter. From the side where there is main bulk of the tumor, if it's midline. Because this is nothing to do with like cerebral hemispheres, which is dominant and which is non-dominant. So it doesn't matter. Some people say that it's better for the right-handed surgeon to come from the right side and for the left-handed surgeon to come from the left side, but I do not really mind. Really depending on the tumor anatomy.
Professor, if there's a tumor, pineal region tumor with a significant intra-third ventricular extension, you still would like to go paramedian, or you will prefer a midline?
Say again.
Pineal tumor with third ventricular extension.
Yeah.
If the tumor goes into the third ventricle quite a lot, you still prefer paramedian, or you would like to go for a midline approach, because that will give you a straight...
Paramedian, and it's very similar to cell meningiomas. You see the coronal cut, and you come from the side where there is less of the tumor. You know, if the tumor is a little bit more on the right-hand side, then you come from the left, because then you see better. And the problem with the third ventricle and the tumors is the lower part of the third ventricle, not the upper part. You see the upper part very well, but you do not see well below the interthalamic adhesion. So the bottom of the cavity is the problem. So the approach is good for upper third ventricle tumors. It's not good for lower third ventricle tumors.
Okay.
And the site doesn't matter.
This is a question for...
Can I add something, John? The Japanese guys, they divided this approach into the lateral one, into the midline, or whatever you name it. And it doesn't matter, because the craniotomy in my hands is always the same. But if you go to pineal region, you go more medially. If you go to CP angle region and the petroclival, then you go more laterally. So this is medial lateral. And if you go more medially, not really along the midline, but close to midline, then your angle of approach is nearly orthograde.
Well, Vlad, this is a question for everybody. Would you ask somebody to share their experience in transtentorial Fowlkes approach?
Oh, definitely, definitely,
Okay.
because that is the competition of this approach, and I would love to hear someone who's got experience with this. I know that some people are using this routinely for all the lesions in the midline, but I did it only several times, and I was not really that happy about it. So if someone would be giving a lecture like that, I would be happy. I
Vlad,
would even suggest
suppose
it would be Sebastian Frelich probably who's using this approach from Paris.
sir,
Vlad,
Yes,
Go ahead, Ike. Go ahead, Ike.
Vlad, I'm going to share a video. Maybe this is something that you probably wouldn't go paramid line. I'm going to show you this.
show me.
Hmm.
See, Ike knows how to work this.
Yeah. He was at the beginning,
He has
was
experience.
blaming you that the videos don't work.
I'm gonna consult him, man.
Vlad, can you see this one?
I don't see anything. I see you, which is
Not
nothing that's
yet.
important.
Not yet.
It's not sharing?
No, not yet. Ike.
Okay. Yeah, 1 second. Sharing now?
Yes.
I see something.
Yeah, you're starting.
No, the video. I see your.
You're going to say wife, huh? What about this one? Vlad.
Excellent one. Excellent one. So show me the sagittal again.
Okay.
Yes. You see, it's upper third, so it's obviously the case for supra-infra.
Yes, but what
Go
about
ahead.
where you really go pyramid line?
Yeah, certainly. Unilateral. Unilateral, and it's more to the right, so I would go from the left. You see
Yeah,
the,
I mean,
the angle. You
just
need
have
to
a
get
look at.
to the right-hand side more. The tumor is extended on the right, to the right a little bit more. So I would come from the left. Yeah.
Okay. Yeah,
Yeah,
because we
okay.
went, we had a problem. We thought maybe if we go pyramid line, the pulvinar is going to come in our way. So we
No.
went midline here. Yeah, just wanted to ask you this. That's all.
Yeah, that's it. That's it. But certainly, if you go via midline, it's easier, and nothing wrong with that. That's a young Sherian, isn't it?
Yeah. I mean, so I just wanted to ask you whether you would go, because the next time it comes, maybe I would like to go pyramid line. In this pineals, I generally go pyramid line. But if there is a third ventricular tumor like this one, I mean,
Yeah.
always the pulvinar comes in the way. That's why I thought I'd go. I mean,
It does, but
midline.
yeah, it's easier via midline, but with less complete. I don't like midline anymore, because it's really extensive surgery. You have more space, of course. And also from the lateral, from a unilateral approach, it's shorter. Midline approach is longer. It's like 3 centimeters longer than the unilateral coming from the side. Oh, not 3 centimeters, 1.5 something. You are earlier there.
Yeah, we have a question that's relevant to what you're talking about. How would you choose the side of approach for a midline pineal region lesion?
That's
He
it.
just answered that.
Oh, I'm
just
sorry.
answered.
I'm sorry.
Contralateral,
Okay.
contralateral.
Okay.
But I love contralateral. Probably someone would think that ipsilateral is perfect and would be working in his hands. This is my experience from cellular meningiomas. I always come contralateral. They never are truly midline tumors. They always are a little bit to the side. And I come from the contralateral because underneath the contralateral optic nerve, it's much easier the work, not underneath the ipsilateral. And this is the same experience or the same philosophy I'm using in these tumors in the spinal region. Contralateral, contralateral, contralateral.
Okay, Dr. Select from Bangladesh asked, do you use an endoscope?
Oh yes, oh yes. We now have this tiny endoscope which comes with Skinevo, and it's an excellent tool. Where I use it mostly is the cavernoma cavity. Brainstem cavernoma, after the resection, I always check the cavity with the endoscope. In these regions, you use it, say, for having a nice anatomy after the surgery. So it's not a working tool, it's a looking tool in my hands.
Very good.
Professor, can I show one image and then can you tell us what you will do for this case? Can I share something?
Yeah.
Image.
Okay.
So,
oof.
Yeah, so this is a 11-year-old boy who had features of Perinod syndrome. So, so we had a lot of discussion. I'll just go through the other images. So we were thinking something like a midline glioma, diffuse midline glioma.
Yeah.
We were not sure of the epicenter, but we thought something maybe or tectal or a thalamic pulvinar or just a midline glioma. So what would be your choice for this type of this tumor?
Well, most likely supra-infra. Most likely. I would need to check the images better, but it's like showing you itself where to go. You have a cyst posterior to the tumor, which would give you lots of space at the beginning. The cerebellum will fall down, so you will have lots of space how to approach the tumor. So definitely, I would go supra-infra. What did you do?
Yeah, I will show you. So what I did is I thought we'll have a combined approach. So this was the position, and so I made a craniotomy both above and below. In the prone position, and I'll just go to the pre-op 1 minute, Professor. So this was the post-op. 1 minute. I'll just share again. Yeah. So what we did is, so almost we could get the majority of the tumor out. And this was the immediate, I'll show you the MRI. So as you see here, this is the craniotomy, which was both supra and infra. So this is a cavity. So we could use majority of the infracerebellar, supracerebellar approach, but also we went paramedian on the para-occipital lobe and got the tumor out. And
Rupesh, we cannot see anything.
You cannot see anything.
1 minute, 1 minute. And now?
No,
not yet. There you go.
Yes. So, now, yeah.
So this was the immediate post-op CT scan. So this was the craniotomy. So as you see, this is the whole thing was a cavity. So you could get almost 80% of the tumor. I'll show you the MRI also.
What was that? A low grade or?
It was a grade. It was a grade 2.
Grade 2.
So yeah, grade 2. And I was actually thinking this is a diffuse midline grade. It will come H3 K27 positive. But to our surprise, it was a grade 2. And what was more surprising was, so this is, I'm just going through the images again. I'm sorry, yeah. So these are all the pre-op. I'm going through that 1 minute. The post-op, yeah. So this is the latest one, as you see here, yeah. So we didn't do any adjuvant therapy. Probably there is something left behind. Probably around 20% of the tumor is there, but you can see that.
Sorry,
so
we can't see
most
anything on this.
You can't see anything.
1 minute, sir, 1 minute. I don't know. I'm sharing.
Yeah, you're back off.
minute.
Go ahead. Go ahead.
So
Yeah,
Yep.
now we can see, sir.
Now we can see.
So we can see that we could shrink the tumor to a significant extent, and we can see that there is a small residual, around 20% of tumor was there here, and we are just following the patient. We didn't give any adjuvant therapy because we discussed in our tumor board, and we initially thought we will give radiation, but we thought we will do a scan again after 6 months, and then we will decide.
I will go for the rest of the tumor now.
No, we thought we will do an MRI again, and after 3 months we have called the patient again, and so we thought we will wait because it's grade 2. Probably he may need a radiation, but our oncologist felt that we will wait for another 3 months, and we will do a repeat MRI, and we'll go ahead.
Excellent job. Excellent job. You know, this is one other reason I like to do it in the sitting. You did it in the prone position.
Yeah.
If you are doing this in the sitting, the blood flows away. If you have a good assistant who is flushing the field all the time, then you it's like with schwannomas, HNF schwannomas sitting again in my hands, because the fluid flows away, so you do not have to suck it that much. And this is exactly the same case, that it flows away by itself. You are saving time. But in your case, which you did an excellent job, and in grade 2, I definitely would consider to go for the rest of the tumor.
Yeah, I thought we may go ahead again if surgically, if after 3 months, or we'll do a adjuvant therapy. What do you feel, Professor? If 3 months later the tumor remains, you should go in again and get the remaining tumor out?
I would go in. In 3 months, I would go in, because you wouldn't like to shoot all your weapons now, like radiotherapy and chemo. You would like to keep it for later when the tumor will upgrade itself. It's my usual policy. The low grades should go out as much as possible. And this looks like flowing in the third ventricle piece of the tumor. And you have space after the first surgery. Do it.
Fine, sir.
Great.
Thank you.
Perfect case.
Good job, Rupesh. Rupesh.
Good job.
Yeah.
Thank you.
Good job. Yeah. What was the vein status? How were the veins like? How were the internal cerebral veins? How was the vein of Galen? How was the basal vein?
Vein of Galen was displaced above, and the precentral cerebellar vein I had to coagulate. The precentral cerebellar vein.
Yeah, I mean, I remember you asking that question. I mean, most of my cases, because I go midline, we always coagulate that vein.
Yeah.
Nothing happens.
Yeah, but other veins are displaced above. So because the tumor was quite big, it itself gave the corridor to go, and we could use. Only it took a lot of time. We spent almost 8 hours for this case, but I think it came out. It was good operating this tumor. It came out quite well.
Why don't you make a good images of the tumor and send it out to the public? What approach would be chosen? Would be interesting to hear opinions.
Sure,
now we agree on supra-infra, but there may be people who wouldn't, and that would be great to listen to these.
Yeah, I'll just if there's a time permits, I'll do a similar case which I did almost like similar tumor. I would like to show if you have time.
Yeah, go ahead, Rupesh. Go ahead.
I would like to discuss this case also. 1 minute. Yeah.
Excuse me, how is the patient post-operative?
So this is the patient. Are you able to see the screen, sir? Images?
Yes.
Yeah. So he is again a 14-year-old boy who was operated initially in another institute 2 years before.
We do not see the images, Rupert. We do not see the images.
No images. 1 minute, sir.
We don't see it yet. No.
1 minute, sir. 1 minute.
Yeah, try it again.
Is it seen now, sir?
Yeah. We are seeing it now.
So he is a 14 or 15-year-old boy when he came. He again, he had a severe intracranial pressure with headaches. He underwent a procedure, biopsy actually it was. They went anterior interhemispheric, prefrontal. But then they could remove only a little bit of tumor, And so this patient came to me, and this is the image. I'll just go through the images. So you see here, it was going bilaterally more towards the right side, but also quite significantly on the left also. And again, I did the same approach, both supra and infra, and I'll just show you the post-op scan. Yeah. So again, the same approach, midline, supra, and infra-tentorial approach.
We don't see the video.
You don't see the
Yeah.
image.
Yeah, 1 minute, sir.
I'm sorry, the image.
Now?
Yes.
Yeah.
Yeah. So this is the corridor. So predominantly I went supracerebellar infratentorial, and I could see that I could get the whole tumor out, and this was a teratoma. As we see here, even I used also the supratentorial, the same approach. I went on the right side, but majority of the tumor I could get by supracerebellar infratentorial lesion itself. And that was a boy. So what would have been your approach, Professor, in this case, if would have gone?
Excellent. The only thing I wouldn't do the U-shaped incision. We are doing straight line.
Okay.
It's easier to heal, and you have a better space when you do the linear, because in your case you have all the tissues downwards.
Okay. Fine.
But, great.
Thank you, Professor.
Nice case. Where from are you, Rupesh?
I'm from Chennai, sir. India, South India. South India, Chennai.
South India, Kerala.
Chennai.
Madras.
Madras.
So not Kerala, so he's not that good, is he?
Yes.
He's very good. Excellent job, Rupesh. Very good job.
Excellent.
Thank you, Professor. Thank you.
Well, if there are no more questions, we would conclude with the sessions now. Very good participation. Excellent talk, Vlad. Parthi is just left, but tomorrow Professor Goyal is going to do a talk. And then after that, we expect many more talks from you, Vlad. Maybe
certainly.
With videos next time.
And videos. No, it's up. The videos are up to you, John.
Okay.
Don't forget to send me link for Atul, John.
Okay.
What I will do is I will send me the videos. I will download it and screen share it for you, Vlad.
I shall find a way. I shall do the presentations and send it to you. John, don't forget to remind me about Atul tomorrow. I will see him again.
This show was just a teaser.
Yeah. Okay, gentlemen.
Yes, sure. See you guys.
Thanks, everybody.
Good afternoon. Bye-bye.
Okay, Ike, I was having a fit because I had to share the PowerPoint and then do the videos too, and I had to leave the PowerPoint. It was like crazy.
You'll find a way. Okay, bye-bye. Rupesh, bye.
Thank you.
Thank you.
Bye. Thank you.
Thank you, sir.
Hey, a lot of people here. Oh, Khalif, how you doing?
I am doing well, John. Excellent presentation by Prof.
Yeah, it's too bad I couldn't see the videos, but yeah, besides that, it was excellent. Besides that, I mean, he has experience, huh?
Yeah.
Yeah, he's been doing it for, I didn't realize his name is so big.
He's a big guy. He's published many books or chapters on.
Really? Oh, okay. Yeah, he seemed to know I don't know neurosurgery, but he seemed to know what he's talking about.
Yeah, of course he does.
So, okay, very good. Well, we have a Spanish lecture in a couple hours, but You don't, oh, tú hablas español?
No.
No, no. No, that's right, you don't.
Poquito, poquito.
If you can't say no in Spanish.
You can say no in Spanish, see?
Yeah, it's the same, no, no. But
Oh.
anyways.
Poquito
Yeah,
Spanish.
poquito español, yeah, but you went to Spain, you went to Alicante, right?
3 months.
3 months.
3 months, John. 3
Yeah,
months
well,
is-
you got by just speaking English there?
yeah, mostly yes. So
Everyone speak, a lot of people speak English there, right?
speaking English, yeah.
So, okay, very good. Thanks for coming, and thanks everyone else for coming.
Yeah.
So we'll
Great.
see you all later.
See you tomorrow.
Bye-bye.